Hello and welcome to Reading. Thank you for coming. There are lots of people here whom I recognize, and I was just going to tell you about the Liaison Psychiatry service that we've set up in Reading. And a number of people in the room have been connected in lots of ways to the service, and I think it's a good example of how we've spanned the divide between mental and physical health. So I'm going to just very quickly run you through what we've done with the older adults liaison psychiatry team in the Royal Berkshire Hospital. The numbers for dementia, especially in the acute hospital, are stunning. 1 in 4 adult beds are occupied by a person with dementia, and the prevalence of dementia increases with age. So it's about 1% at the age of 65, goes up to almost 33% by the age of 95. And thinking about it, so that's almost 1 in every 3 people at the age of 95 who might have a cognitive impairment. In the acute hospitals, things are different. They're actually worse. So a number of people have dementia a lot earlier. So it's 40% of people over the age of 75 who have dementia. And a number of these, up to 50% of these people, are never diagnosed prior to coming into the acute hospital. So liaison psychiatry has a major role in picking up these people who would otherwise never be picked up and never have a diagnosis of dementia. These are numbers in Berkshire. These are about three years old, so they aren't up to date, but they do show what we'd call the demographic gap. So quite a big gap between the actual number of people on GP dementia registers and the predicted prevalence of dementia. And we're hoping that we are picking up on these people as they come through the general hospital. Dementia is very expensive, and this is a slide I've taken out of a comparison done by the Alzheimer's Research UK, which shows that dementia actually costs more than cancer, costs more than heart disease, costs more than stroke. You will notice that the costs are more in social care as compared to healthcare costs. But I think with the pressures on social care, we in health are increasingly feeling the pressures. And you know, this is something that needs to be thought about in terms of the health economy. So people did start thinking about this, and I think the first serious reports started coming out by the middle of the last decade. This is the first report that came out, which suggested that in a 500-bed hospital there are about 220 beds occupied by people over the age of 65 who have a mental disorder, so a huge number. And almost all these people had no access to mental health care. The National Dementia Strategy came out in 2009. And I think there was a huge push, lots of public awareness about dementia that came with the National Dementia Strategy. And these were the 3 major themes that were put together. Awareness, early diagnosis, and most importantly, improved quality of care. So there were 16 or 17 themes that came with the National Dementia Strategy, and the ones in the middle probably are most relevant to us who work in this field of the crossover between medical and physical health. Improved care in general hospitals, improved intermediate care, and increasingly now improved care in care homes and end-of-life care. So all these policies came about, and then came this report. And I'm sure we're going to see this about 4 or 5 times through the course of this evening, because this report actually showed that liaison psychiatry services were not just kind of touchy-feely, value-added services. This actually showed that, and it's the last point there, it saved quite a lot of money. So for every £1 that was invested in the liaison psychiatry service, the acute trust was saving up to £4. They showed that they were able to reduce length of stay, they were able to increase discharge rates from wards, prevent people from going into care homes, and also reducing readmission rates. And I think so, since the time this RAID report's come out, this was in City Hospital in Birmingham, there have been there's been quite a lot of interest in liaison psychiatry services. So the College of Psychiatrists put together a plan, so the Psych Liaison Accreditation Network. This is sort of loosely put together pack which served as a commissioning guide, a bit of a peer support network between liaison psychiatry services, but most importantly, I think has begun to serve as a benchmarking process. And I think that's something that we are looking at least that's my interpretation of the AHSN, looking at benchmarking services, assuring ourselves that we are delivering a certain standard of services across the entire patch. And that's what the plan network is beginning to do. We've had our plan inspection. I was hoping I'd be able to tell you we had the accreditation was excellent, but apparently the committee hasn't quite sat down yet to decide on whether they've accredited us. So we set ourselves up based on the plan guidelines. That's a picture of us getting an award. So we didn't look that way when we set ourselves up. But no, I think we've got to give our commissioners due, because we said, this is a team that's going to work. We're going to be able to do things in addition to just providing a service, chasing our tails, trying to sort of sort people out who are delirious, psychotic. And they said, yes, go for it. And I think we've been able to do that. So in addition to providing a clinical service, we provide training. We've been able to do some number counting. We've been able to do a bit of research. And I think all this has benefited. We've done a bit of work in St. Thomas's in 2010, which looked at referrers as a source of looking at how we could benchmark quality. And we set ourselves up according to what referrers wanted from a service. So 3 main themes were what we looked at, and I think we keep working to this. And it really does push the members of the team quite a bit, but I think these are our focus. These are the areas we focus on. So it's all about speed, trying to make sure people who need to be seen urgently are seen within 4 hours. People who need frequent reviews are seen and seen as frequently as they need to be seen. We try to be proactive, go into MDTs, pick up on things earlier rather than wait for a crisis. Quality, it's hell, because we've got to do 2 sets of notes. So we write in the medical notes, we also need to translate things onto the electronic notes. And we try to pick up as many new dementia diagnoses. We try and actually check that GPs are referring people on to memory clinics so that we close the loop on people we see. And there's also a big focus on what our referrers and patients want. And I think we've had good feedback from referrers, from our patients, and from their carers. We've also done quite a lot of work looking at our customers. So in some ways, I think the medics who refer to us are our customers. We've discovered that nurses are very different from what they want of a liaison psychiatry service from the consultants and the other senior clinicians on the ward. So nurses see themselves as being on the front line, as being patient advocates. They'd rather we give them a verbal handover, tell them what to do right there on the ground, as compared to consultants who only come onto the wards when they're on their ward rounds, want a very brief summary of risks, and want written notes. And I think working on these various streams has made a difference to how happy people are with the service we provide. We also are very fortunate in having a dementia steering group. This was something that predated the liaison psychiatry service. So this is set up by Professor Oliver. Involves almost every single group that's involved with dementia care across West Berkshire. Patients, carers. We also have people, Rosemary Croft, who's somewhere in the audience, has started coming to this. She's our dementia lead for West Berkshire. So I think we have representation from everyone connected with dementia, and that makes a big difference to us. We've got the year of the board. So we decide on things, say these are the ways we're going to do things, and they do happen very quickly. And I'm hoping with the AHSN there'll be a bit of university coming in there, we'll be able to do a bit more number counting, be able to do a bit more in terms of research, and hopefully this is where we're going. We sit, as with any other liaison psychiatry, we sit between acute and mental health care, and it's always a battle, and I think we've set ourselves up to actually sit with the Elderly Care Directorate in the Royal Berks, and that makes quite a big difference. So we've got a joined up approach to our governance, to our incident reporting, dealing with complaints, and helps us sort of get things moving fairly quickly, and that helps quite a lot. Our referral rates, these were a lot higher than we initially expected. We generally see about 70 patients a month, goes up during the winter, and I think roughly that's equivalent to a small CMHT with a much smaller team. So if we see people very rapidly, discharge them and see quite a few people. Not all our patients have dementia. A third of people have functional illness, so people who are depressed, have health anxieties, are psychotic. We see them as well, are able to get in, treat them fairly rapidly. And we also have been able to do quite a lot of training. So we've started a Dementia Champions program within the Royal Berkshire Hospital, trying to sort of train up all staff across all areas. And I think focus in on the 4D, so that's dementia, delirium, depression, and dignity. And I think we've been fairly successful. We're just about starting our second year of this. Come up with various assessment tools, helps reduce antipsychotic use in people with dementia, helps quality of their care within the hospital. I know Alison's going to be talking about some of these projects because she helped us put these things together. And we've also been able to look at what I'd say are fairly common clinical quandaries in people with dementia in the elderly, hyponatremia in people who've been treated for depression with SSRIs, antipsychotics in dementia, sleep problems in people with Parkinson's, and I'm hoping we'll be able to do a bit more of this over time and with a bit more resource. We've just had the second round of the National Audit of Dementia, 7 themes that were looked at, and I think the RBH has ticked most of them compared to 2 years ago, and this is all, I think, due to the input from the team. These are my last 2 or 3 slides, Susanna. This is a report from the Dementia Action Alliance, and this could be the result of the liaison team, this could be a result of other initiatives within the RBH, but I think we're doing pretty well in terms of excess length of stay. So that's the whole country, and West Berkshire comes up around there. Number of excess falls in hospital for people with dementia, seem to be doing pretty well there as well. And we've just about begun to look at whether we're having any impacts on length of stay, and sadly, as of now, we aren't. But I think we are beginning to show that readmission rates have dropped away in the group of people that we've seen. So that was everything about liaison psychiatry for older adults in a nutshell. So thank you very much.